came in hypotensive from the field, with intubated in the field without any paralytic posturing. She was a GCS of 4T on arrival. And she was obviously trauma activation. They call us. First or second year, he wants a crack.
Axial non-contrast CT. See a right subdural hematoma. Looks like hyperacute with significant effacement of the right hemisphere. Basal cisterns are compressed. You see at least probably 8 or so millimeters of midline shift.
I'd say put it that
Like
way.
8 more, 8, 9. I don't know.
I'll say 14.
14.
It's kind of hard to tell.
Well, I see the bulks right there.
Oh.
Here?
I'm gonna say 20.
Okay. Just guesstimation, not precise science.
Did you give her lactated injury?
Yeah.
So,
Roll an 8.
yeah. Thanks.
So, okay, so what else do you see? Well, make some more comments on this CT one.
So the basal cisterns are compressed. It looks like
Comment on the amount of shift compared to the size of the hematoma.
yeah, the hematoma is the amount of shift is kind of disproportionate to the size of the hematoma, suggesting like a lot of edema. Would kind of preoperatively, you would think you might want to do a decompressive craniectomy because you'd have a lot of swelling. You wouldn't be able to put the bone back on after going in.
It's kind of what we talked about. Well, you already see really bad
Loss of
sulcite pattern, the brain was kind of dark. So the fact that she was hypotensive in the field kind of makes sense. You're already thinking this is maybe like and she's posturing, so she's kind of marching down the brainstem in terms of dysfunction.
Was she the passenger?
She was All right, so what do you think?
She was.
Are there any fractures or?
Not really.
Anything on the C-spine?
We want to make sure you measure certain numbers here, right?
Yeah.
Powers
ratio, BDI.
This number, right? What's this number supposed to be in adults?
The size is 12. 11.
I think it's 170, right? This number is like 3 or less, right?
3 to 7. 7. No, I'm thinking
Point
of
three.
that size. Oops, sorry.
This number here,
That's 2. Or 1.4.
1. Anything greater than 1 is pathologic. So I think all these numbers look okay, but this might be marginal. When you're thinking high mechanism, you want to look at those numbers. Okay. So what's the timing of surgery?
Timing. She's 35. She comes in. You got to make sure that is she hemodynamically stable? Like she was hypotensive when she came in. Is she on any kind of pressors or anything?
As long as anesthesia is, I mean, you just have to take her right away, you know, there's no waiting.
I mean, it's got, yeah, I mean, my thought is it has to be emergent, but I mean, if she's unstable, I mean, that's my only hesitation in taking her to the OR right away. It's gotta make sure she's hemodynamically stable before we get her on the table.
As soon as possible.
Yeah.
Yeah. That's what we did.
Well, she also has another treatment for it, right? Or-
Yeah, I mean, it's
Yeah.
kind of hard to tell, you know, it's really kind of muddled, there's definitely a acute component. So this is kind of not a shining example of what a decompressive craniectomy is, kind of why I wanted to present this too, is kind of a undersized on the cranie. This patient became difficult to bag, wasn't. They were having difficulty getting her peeled or her SATs up, and as soon as we got in, I think she had bad pulmonary protrusions, and I think she went in with her SATs were kind of. I think she started at 92 and then just went down from there. So this was kind of a rush job to kind of just get pressure off the brain and get her off the table as quickly as possible. So her stats kind of were up and down. I think at one point she was even in the 70s. So she was crashing hard. And so we kind of did a not ideal size craniotomy. This craniotomy should be a lot bigger. You know, there's barely any temporal decompression here. So this is not the way you want to do your craniectomy. But this is, as soon as we opened up, the brain was hard as a rock. There was no pulsations. This is the one, Dr. Beamer, remember we were doing the surgery and we kind of had things kind of sort of semi-calmed down, and a cortical vein just exploded and just geysered up without us even touching it, doing anything. I mean, her brain was that bad and the pressures were really high in her head. So at that point, with the SATs going down, we kind of just did the best that we could, and we didn't want her to code on the table. Have to do CPR in the OR.
What was her GCS?
Four. Given the story, how young she
reacting, non-reacting?
they were like very sluggish, but they were reacting to it. But given the story, how young she was. Yeah. So this is kind of, we tried, but she didn't have a good outcome, and just as kind of to show you guys how maybe kind of not to do the craniotomy. If this was like a more controlled environment, you really want to get back here and make this cut. You really want to get down low and take this temporal component off, because that's where you're getting your maximum decompression is from removing the temporal bone and allowing the temporal lobe to shift off of the brainstem. That's how you're saving the patient.
Did the stats come up once you decompress?
I mean, I think they came up a little bit, but I think they were like hand bagging her at this point with 100% FiO2, and she was still going up and down. So.
She passed away, right?
Yeah, she was after we got her off. She was fixed and dilated after we got her off the table. She wasn't, she wasn't. She still had vital signs, but she didn't have any brainstem defects. Kind of like this.